Can you hear us?
Meera, if you have anything in between, you can interrupt me anytime.
Yeah, sure, ma'am, sure, ma'am. Nilesh? Dr. Nilesh, are you able to hear us? Hello? I think there's some network issue probably.
Yes.
Dr. Nilesh?
Digvijay, can you call Nilesh?
Yeah, I am calling him. निलेश तुला ऑडिबल आहे का? Can you be bit louder? Actually, he is not able to hear anything. There is some connection issue, I think.
Hello? Digvijay, now am I okay? Hello?
You are audible to me. Nilesh, can you hear
Okay.
Abhilasha?
Can we ask him to just exit and reconnect? Probably that would solve the issue.
Yeah, that would be ideal.
Yeah.
Just a minute. I'm just calling him.
Hello. Hello.
Yes, Nilesh, you're audible.
Yes, ma'am. Sorry, ma'am. Sorry for that.
No problem. No problem.
Yes,
Yes.
ma'am.
Abhilasha,
Yes,
ma'am.
Nilesh, it's okay.
Yeah.
Hello, Nilesh?
Yes, ma'am.
Yeah, start with the first slide.
Yes.
If I'm not audible, I'm not clear, please let me know, okay?
Yes,
Just to
ma'am.
interrupt, our time is till 11:50 p.m. Uh, After that, we have a lecture of Himanshi ma'am. So that is to let you know. We can do till 11:55 also.
I
Okay.
will take 10 minutes only. Don't worry. So, Nilesh,
Yes.
your chief complaint should be chief,
Yes, ma'am.
3 or 5. Okay. And whenever you are second slide. So whenever you are giving HOPI for presentation, it's okay for points, but your HOPI should be in a form of like a story.
Yes,
Okay.
ma'am.
And in patient language.
Yes, ma'am.
Okay. They don't know the cervical area. They can
Yes,
tell
ma'am.
you about the neck thing. So when you are starting HOPI, you okay, I am convinced with the inflammatory nature and additive that you took very well. That inflammatory nature of history, additive, very good, small joint.
Yes,
But then neck pain, you have not elaborated the neck pain. I don't know what I'm dealing with, whether it's radiating or it's causing any weakness, or it is like it has any other characteristic features that I want to know in history only. Okay.
Yes.
After that, again, when you'll tell next slide,
Yes.
when you'll tell about the nodules, you should be like in patient language, whatever they are thinking, where it came first, and
Yes, ma'am.
what they are thinking, not what you are thinking in history.
Okay, ma'am. Yes.
Okay. So from starting only, you started fixing your head that it's a RA nodule only. There are
Yes.
multiple nodules will be there. Okay, in
Yes, ma'am.
like in arthritis case or in any cases. Understood?
Yes, ma'am.
Okay. Now the skin lesions. Whenever the skin lesions will come, there are again the n number of causes are there for
Yes,
the
ma'am.
skin lesions. Agreed?
Yes, ma'am.
Okay. So
Yeah.
tell me the what other skin lesion will get in RA, because again your skin lesion you have not elaborated properly.
Yes, ma'am. In skin lesions in RA, if it is a chronic disease, we can expect with extra articular manifestations, we can expect rheumatoid vasculitis. Other lesions can be like venous stasis, dermatitis can occur, eczematous lesions can occur, hyperpigmentations, and purpuras can occur because of other causes like IgA vasculitis, thrombocytopenias, ANCA-associated vasculitis, or drug-induced vasculitis also can occur, ma'am. And cryoglobulinic vasculitis, in which arthritis is also present. And
Good.
ma'am, SLE vasculitis can also be found. But if there is anti-DHD NA positivity, but along with that, we have to look for malar rashes, sense of nephritis or low complement.
Okay. And
ma'am, polyarthritis nodosa can medium vessel vasculitis.
yes, can I have next slide for skin lesions? So see here nodules, here skin lesion should be like whether we are dealing with painful or painless. What as per the history only, not your examination
Yes,
again.
ma'am.
Okay, so how what color is this? Whether associated with itching or not,
Okay, ma'am.
not there.
Whether
And
it is
there are
maculopapular or it's
yes,
just erythema, that is also very important because that will help you categorize what kind of a skin lesion are you dealing with.
Yes, ma'am. It is a plain purpura, ma'am. No itching, no discharge from it, and no non-painful, ma'am.
Okay. And you need to even ask whether it is waxing and waning or it's persistent.
Okay.
Because if it is stasis and gravitational, then you might have a waxing and waning episode wherein when they stand, you get it, it increases. And the moment they rest the feet, it disappears. So you
Yes,
have
ma'am.
to ask all those questions, whether there are any aggravating or relieving factors for the skin lesions as well.
Yes, ma'am. Yes, ma'am.
okay.
I'll correct that.
And if you'll see, if you'll go back to Hirschberg, there are like you will get more than 10 causes for in dermatological manifestations
Yes, ma'am.
of RA. So it include anything from pyoderma gangrenosum to interstitial granulomatous dermatitis,
Dermat.
erythromelalgia.
There's
Even one crescent sign is there.
you,
You know what is crescent sign?
No, ma'am.
So whenever that Baker's it will get rupture,
Yes, ma'am. Yes.
you will get skin lesions. You know that, no? So in the
Yes, ma'am.
same area you will get the skin lesions. So
Okay.
you have to convince me that no, here we are dealing with the vasculitis, not other
Yes, ma'am.
skin lesions. Okay.
Yes, ma'am. Yes.
Okay. Next slide.
I just had one thing to say.
Yes, ma'am.
You should never commit clearly to rheumatoid nodules just based on a history. It
Yes.
could be anything. It's a finding that has to be confirmed on examination. So, in your
Yes, ma'am.
history, never be very dogmatic and comment that it is a rheumatoid nodule and it is cutaneous vasculitis. You can
Yes, ma'am.
always say that you're suspecting that.
Yes.
Don't put it upfront as it is, don't commit to it that it is a rheumatoid nodule and it is a cutaneous vasculitis. Because on examination, rarely you might just be surprised that it is something else altogether.
Yes, ma'am.
Okay. So like don't write rheumatoid nodules or
Yes, ma'am.
don't tell that. Next slide. And not even cutaneous vasculitis because you have not examined what is that skin discoloration. So that you have done very extensive. I just want to know why you have asked conjunctivitis and what else?
Yeah.
Urethritis and diarrhea.
Yeah,
Ma'am,
yeah.
to rule out reactive arthritis, ma'am.
See, it's your story which will tell you which negative history you should ask. There are
Okay, ma'am.
100 negative histories are there, 100 differentials are there. If you will tell me just joint pain in 15 days or 21 days. But
Yes,
if you are telling me there is a joint pain with deformities are there 25 years, then you cannot think about a reactive arthritis. And
yes,
okay,
Really
yes,
agree.
ma'am.
So now at the end of the history, you are only committing that we are dealing with. First, you should not commit about RA nodule or RA vasculitis in history
Yes,
only. You
And
just sum
even
up the summarize.
sorry, and even seropositivity on history, you cannot say whether it is seropositive or negative. That's a laboratory finding, right?
yes, ma'am.
So you should not say that at the end of your history that it is a seropositive disease or not.
Okay, yes.
So at the end of history, just summarize the history, keep your positive findings only, and nothing else. Don't commit anything.
Yes, ma'am.
Okay. Now
Yes.
after committing, don't give again extra differential. Like the history is too good. It's telling that 25 years of his inflammatory, deforming, additive joint pains are there.
Yes, ma'am.
Then suddenly you started with psoriatic and gout.
Ma'am,
Do
but
you
we
think
can
gout will present with 25 years continuous additive, or
no, ma'am.
SLE
No,
will present with that?
no, ma'am. Not at all.
Yeah, you know that all three are like different presentations are there.
Yes,
Even
ma'am.
psoriatic arthritis, I can like 15 years. I will wait that after that skin lesions are there. Or there is no typical skin lesion of psoriatic arthritis.
Yes, ma'am.
So y- don't think about psoriatic arthritis. Don't think about gout. Don't think about SLE.
Yes, ma'am.
Okay. So
Yes,
10
ma'am.
minutes. I finished here.
Yeah.
Mira.
Yeah, no, I agree with you. Your negative history doesn't have to be so extensive. It just has to be to the point what is relevant to the history that you've presented.
Yes, ma'am.
And just be as crisp as possible so that you get the entire story in one go and it's not in piecemeal, like bits and parts here and there. Otherwise, you presented well.
Yes, thank you, ma'am. Yes, I'll correct all the rest of the things.
Yeah.
Yes.
I think we can go forward to the examination, ma'am.
Yes, yes.
Okay. Yes. Yes, thank you, ma'am. On general physical examination, a patient is conscious, cooperative, and oriented to time, place, and person. Pulse is 86 beats per minute, regular, normal volume. Blood pressure is 134 by 84 millimeter of mercury on right arm in sitting position. Respiratory rate is 16 cycles per minute, regular. Temperature, patient is afebrile. SpO2 is 98% of on room air. Anthropometry says weight is 52 kg, height is 160 centimeter, and BMI is 20.3 kilogram per meter square. On examination, there is no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or pedal edema. On skin examination, cutaneous vascular, sorry, ma'am, multiple non-blanchable purpuric lesions over bilateral ankles and dorsum of feet, and firm non-tender mobile over underlying structures and extensor aspects of both elbows, normal overlying skin, and no ulceration or discharge, and non-painful. And these are the photos. For the first one on the left side showing purpuric lesions over bilateral ankles, and also on the dorsum of feet, and there are photos next to them on the posterior aspect also. And on the one on the right side shows nodule on the extensor aspect of the elbow. This one is of the left elbow, and so on the second slide it is of the right elbow, ma'am. On further examination, patient has stoop posture, difficulty rising from chair and walking. On hands, examination of hands, ulnar deviation at MCP joints, metacarpopharyngeal joints, swan neck deformity of multiple fingers, and no active ulcers or digital gangrene.
Nilesh, when you are finishing, finish head to toe examination there only.
Okay.
Okay. Here now, if started here skin manifestation, I'm interested at whether other manifestations of RA vasculitis or any vasculitic feature or any other CTD features are there or not in head to toe examination.
Okay, ma'am. Okay. There is no ulceration, no discharge. There is no nail fold gangrenes, no digital gangrenes. Only cutaneous manifestations on bilateral ankles and feet that in the form of non-blanchable purpuric lesions. And only firm non-tender mobile over underlying structures, nodules present only on bilateral extensor aspect of elbows, not on any other bony prominences. Should I continue, ma'am?
Yes.
Yes, continue.
On musculoskeletal examination, patient has stooped posture with difficulty in rising from chair and walking. On examination of hands, bilateral hand deformities are noted in form of ulnar deviation at MCP joints and swan neck deformities involving multiple fingers. There is no active skin ulcer or digital ganglion. On examination of the feet, there is bilateral hallux deformity. On examination of elbows, there is bilateral fixed flexion, a loss of terminal extension. These are the photos of bilateral hands showing swan neck deformities and ulnar deviation.
Is there a Z deformity as well? It seems in the
Yes,
right
ma'am.
thumb.
On the
The
right,
right thumb.
on right thumb, there is a Z deformity.
Okay. Okay.
Yes, ma'am. On palpation, there is tenderness present in 7 out of 10 MCP joints and 4 out of 10 PIP joints, and also in bilateral wrists, elbows, shoulders, and knees. Swelling is present only on the elbow joints, as shown in this picture. And restricted range of movement is present in metacarpophalangeal joints, proximal interphalangeal joints, wrists, and elbows. Range of movement is normal in shoulders and knees. And painful range of motion is present in all the affected joints. And there is no significant redness. Currently, there is no significant redness or warmth appreciated in any of the joints. And that's for the musculoskeletal examination, ma'am.
Knee.
So,
1 minute. Knee is just tender, nothing else.
No, ma'am. There is no restricted range of movement.
Then why is he
There is
having
no
difficulty walking and getting up?
Patient had history of TKR, and there is only pain, ma'am. There is no pain and tenderness. There is no swelling, no redness,
Then
and no
why?
restricted range of movement.
Then
Because
why
of pain, ma'am.
because of pain, he's not able to walk.
Yes, ma'am. Difficulty in walking, and there is also pain in hallux deformity in bilateral feet, and there is also pain.
So, Nilesh, normally when you present a musculoskeletal examination, you know what is GALS?
Also, no.
So GALS is something known as gait, arms, legs, and spine.
Yes.
So that is, you inspect first, you look for all the deformities. Then when you go for palpation, you always go from the proximal to the distal joint or distal to proximal. Everyone has their own preference, but it's a pattern that has to be followed. So once if you're going from upper limb, if it is proximal to distal, then you first describe the shoulder, then the elbow, then the wrist, and then your MCPs and PIPs.
Yes.
And the same goes for the leg. So when you are talking about palpation, then the restricted range of movement, deformities, everything has to be in one breath.
Okay.
Okay? Yeah. Continue.
Yes.
So Nilesh, whenever we are starting examination of MSK or some head-to-toe examination, first you should know what are the complications of long-standing RA, rheumatoid arthritis.
Yes, ma'am.
So in head-to-toe examination, can you just enumerate what are the what we are looking in a long-standing RA?
In long-standing RA, ma'am, first of all,
What are the complications? Yeah.
Yes, ma'am. Joint deformities is the first and foremost, and then after that, rheumatoid. We have to look for nodules, vasculitic lesions.
Okay.
And joint deformities for first small joint followed by large joint, and
That you already told, yes.
is there any cervical joint involvement, neck involvement?
Okay. And else? What else?
That's it, ma'am, actually.
Any other feature of secondary Sjogren's syndrome is there or not? Any other features of malignancy is there or not? Okay. And any other cutaneous features are there or not? Okay.
Yes, ma'am.
So you have to tell whenever you are starting, just don't start like from down, like up to toe. It's head to toe. Okay.
Yes.
So you have to tell that if dental case is there or not.
Right.
What about the sclera? If scleritis is what is that? Any other abnormalities are there or not? Okay.
Yes, ma'am.
So head to toe examination, here we are dealing with RA with some vasculitis or some other other complications. So we have to rule out other patient has any other complication or not. Ayurvedic patient is on Ayurvedic medication, then you have to find out any Cushingoid habitus is there or any other steroid related features are there or not in your patients.
Yes.
Again, the examination, that first slide should be your that's last slide. Okay, you should start with that warmth and other things, and after that at the end with deformity and range of motion will come, because once you will tell the deformity and then we will think about that range of motion. Okay.
Yes.
Okay. Now, can you show me the picture of your deformities?
Hand
Can you
deformity.
tell me the mechanism of your Butner deformity?
Ma'am, because of chronic inflammation, autoimmune inflammation, there is chronic synovitis, which leads to pannus formation. Because of pannus formation, it is thickened and hypervascularized. The pannus invades the articular cartilage, subchondral bones, ligaments, joint capsules, and leads to production of, because of that, there is production of TNF alpha, IL-1, IL-6, IFN gamma, which leads to osteoclastic activity and the erosion of cartilage and tendons, which leads to joint laxity and deformities. And it also affects muscles, which leads to unequal pool of extensor and flexor muscles, which leads to permanent deformity.
Dr. Nilesh, what is Boutonniere deformity?
In Boutonniere deformity, there is, ma'am, PIP flexion, proximal interphalangeal joint flexion, and distal interphalangeal joint hyperextension.
Yeah. So Dr. Abhilasha is asking, why does that happen? What is the mechanism for that specific deformity?
For, ma'am, specifically for Boutonnieres.
So basically, because of the disease activity, there's rupture of the central extensor tendon.
Yes.
So that is why your PIP starts buttoning up from your position, and your lateral bands then lead to that flexion, which causes the flexion at the PIP and hyperextension
at the DIP. Yes.
Okay, so that is the reason for the Boutonniere deformity.
If you want to remember, you can remember like buttonhole, how we are like buttoning your shirts, no?
Yes.
How we are putting your button and that sleeves will go inside of that button. So buttonette to buttonhole. Okay.
Yes, ma'am.
So if a patient is there with deformities, then you should know all the deformity. Okay. Yes, all the deformity and their mechanism.
Mechanisms.
Yes, should I ask other deformity? Like,
ma'am, I know what deformities are, but mechanism of each is a little dicey, ma'am.
Okay, no problem. Then we'll go with the deformity. What is mallet finger?
In mallet finger, man, there is a flexion of the DIP joint and extension of PIP joint, ma'am. Like a mallet.
Only flexion of the DIP joint.
Yes, ma'am.
Okay. And what else is there?
What happens in a Z
piano?
Oh, sorry, ma'am. You please continue.
No, you okay? Your patient? I cannot see that other ulnar aspect. Is your patient has piano key deformity, or can you explain what is piano key?
Piano key.
It's okay.
So your ulnar head, no? It is because of your ulnar head subluxation.
Yes, the
so it will cause your
prominent. Yes, ma'am.
Yeah. So your ulnar head will become like prominent, and when you will try to press that, it will depress more than 5 mm. Then it's ulnar. It's like a piano key.
Piano. Yes, ma'am. Yes.
Okay. Meera, please.
What is Z thumb deformity? What do you exactly get in that?
Ma'am, in Z thumb deformity, there is MCP flexion and subluxation, and interphalangeal hyperextension, and CMC joint subluxation.
Yeah, CMC joint subluxation, I'm not really sure, but the first two are right.
Yes, ma'am.
What you said is correct. What other deformities do you know in RA?
Ma'am, swan neck deformity can occur, in which there is a PIP hyperextension and DIP flexion. Ulnar drift can occur, which MCP joints deviated towards the ulnar side. There is MCP subluxation causing a volar and volar subluxation of MCP joints. These are in hand joints, ma'am. There can also be deformities in wrist, elbow deformities causing fixed flexion deformity and loss of extension. In cervical spine deformity, we can, sorry, ma'am. In wrist deformities, carpal collapse can occur, carpal instability.
In toes, in the feet.
Ma'am, hallux valgus can occur in which there is lateral deviation of the great toe. Claw toes can occur, which causes MTP hyperextension with PIP and DIP flexion. Ma'am, hammer toe can occur in which there is PIP flexion and a relatively extended DIP, which makes it look like a hammer. And cock-up toes can occur because of hyperextension of MTP joints, ma'am. And in cervical spine deformities, atlantoaxial subluxation, C1, C2 instability due to a transverse ligament destruction can occur, ma'am. Also, basilar invagination can occur.
These are not deformity.
These are not. These are cervical
complications.
We are going into radiography. Okay. So, can we have the slide with skin nodule? So we'll confuse you a little bit. Okay, Nilesh?
Yes, ma'am.
So tell me why you are thinking that this is a RA nodule.
Ma'am, because yes, ma'am.
Like I am thinking that is gouty nodule. Then
ma'am, RA nodules, it is, I think it's an RA nodule because it is firm, mobile, painless, and mobile over the underlying structures. And in gouty nodule, ma'am, there is history of long-standing gout. It is firm, irregular nodule, and most probably it is seen on. It can also be seen on ear pinna, and there have been chalky, a little bit chalky discharge can be found.
Yeah, excellent.
Yes.
But the position wise, what is the most common position of RA nodule? And have you checked about the other area of RA?
Yes, ma'am. Yes, ma'am. On the extensor aspects of forearm, extensor aspects of finger, on the sacrum, rarely can also be found in the occiput and scalp, but olecranon is the most common location, along with the extensor aspects of forearm and extensor aspects of finger.
So there's only one nodule is there?
Yeah, on bilateral elbows, ma'am. One on right and one on left, ma'am.
Okay.
Yes, ma'am.
Nilesh, what is accelerated nodulosis?
Ma'am, in diagnosed patient of RA on methotrexate and probably controlled disease activity, methotrexate causes accelerated nodulosis. It can be differentiated from RA nodule because they are smaller in size. They are less than 5 mm, but less than 5 mm and multiple in numbers. And in that patient, methotrexate patient is already on methotrexate with controlled disease activity.
So does it warrant further immunosuppression or upgrading? What do you say?
No, ma'am.
Immunosuppression?
Actually, patient's disease is actually controlled, so there is no increase of escalation of immunosuppression, ma'am.
What is the mechanism for it? Okay, you read it up. You read it up. You will come to know.
Yes. But no escalation, but
we can de-escalate the treatment.
No, you continue on the same, and it has also been described with etanercept. Obviously, commonly with methotrexate, but sometimes it has been described with etanercept also. And you're right, it is well-controlled disease activity. Basically, the adenosine increases, which leads to that.
Yes.
Through the methotrexate mechanism of action.
Yes.
Yes. Yes, ma'am, you were saying something?
Nilesh, can you just tell me about the leg findings?
Patient has hallux valgus, ma'am.
Hairs are there or not in legs, both legs? Because that picture also I'm not able to see any hairs or legs.
No, so there is loss of hairs in bilateral lower limbs.
Why? Even that first also there is I'm not able to see that hairs, no?
Yes, ma'am.
And that previous slide also, I think it's a previous slide. No. That leg.
This one?
Yeah. So, Yeah, I'm not able to appreciate any hair. So
Yeah. Long standing, it seems to be.
Yes, ma'am.
so
There is
is
absence
there
of
a hairs on? Yeah.
there is absent of hairs on lower limb.
So what 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 is the significance of this?
Hmm.
So in a long-standing RA, there are more risk of peripheral arterial disease or even coronary disease. Everything like
Okay. Yes, ma'am.
there is more risk of atherosclerosis everywhere.
Yes.
So whenever you are doing examination or general examination, pulse along with pulse examination, just see other pulse examination. Okay.
Yes, ma'am. Peripheral.
So
Yes, ma'am.
whenever hair like your big toe hairs are less or there is absent, just think about, are we dealing with any like decreased flow because of that these features are there or not?
Yes,
Okay.
ma'am. Yes, ma'am.
So are we dealing with any other diseases, and that's why skin findings are there, because your skin findings are not looking like right now leukocytoclastic vasculitis on examination,
Yes,
not even looking like any ulcers.
Hmm.
Okay.
Yes, ma'am.
So right now only as per the examination, I can see only it's palpable.
Palpable purpura, ma'am. Palpable purpura, ma'am.
Okay.
Yes, ma'am.
So have you examined that peripheral pulses?
Yes, ma'am. All the peripheral pulses were present. I examined, ma'am.
Okay.
Yes.
Next time.
So on systemic examination, cardiovascular system, all the rest of the systemic examination was normal. On the cardiovascular examination, S1, S2 were heard normally. There were no murmurs. On respiratory system, bilateral air entry equal, no vesicular and normal vesicular breath sounds, and no adventitious sounds were heard. On CNS examination, higher mental functions were normal, and there were no focal neurological deficits. There was no upper limb. There was no limb weakness, gait imbalances, bowel or bladder involvement, paresthesias or features of suggestive of cervical myelopathy. An abdominal examination, abdomen was soft, non-tender. There was no organomegaly, and bowel sounds were present, ma'am. These are the ma'am images of scans which we had of the
So
patient.
if you are telling like from starting only, we have just skipped that cervical neck pain, no, the neck pain. We
Yes,
have
ma'am.
given least importance to that. So whenever you are like starting, you have to elaborate what kind of neck pain is there. Examination also, neck examination is important. Like neck examination is important if you're or you don't have any like planters and everything is normal, then you have to
Yes,
check the
ma'am.
flexion and rotation. Okay, because
Yes,
here
ma'am.
you are telling about the neck pain, and we don't know still now what is happening with the neck. Is it
Mm,
because of atlantaxial dyslexation, or it is because of something else?
yes, there is
Okay. So
cervical tenderness, ma'am, and a decreased range of motion. But there is no other symptoms like upper limb weakness or paresthesia, tingling, numbness.
The
that you
reflexes
have
are
to
fine.
Yes, ma'am.
You check the reflexes, right?
Yes, ma'am. Reflexes are normal.
Okay.
All limbs.
So here you have to elaborate a little bit on CNS examination if you are telling about the neck. Even in your OPD, if
Yes,
a
ma'am.
patient is telling about neck examination, always and always first check the plantar before checking your neck. Or are we dealing with some kind of
Compression.
atlantaxial dyslexation or a compression? Okay.
Yes.
Uh, okay. So I don't need like a CNS examination is normal.
Yes, ma'am.
How to elaborate? Okay.
Yes.
Yes. Next.
Yes, ma'am. We have images of the patient's scans, ma'am. We don't have a CT scan report, but cervical CT scan. We have cervical spine CT scan. Which shows. Sorry. Hello.
Yeah, you can tell us the finding.
Hello. Am I audible? Hello.
Yes, you're
Yes,
audible.
Nilesh.
You're audible.
Hello, Nilesh.
Hello. Yes, ma'am.
You are
Uh,
audible.
yes, ma'am. We can see multi-level cervical spondylosis and anterior osteophytes can be seen, ma'am, as such as I think so. But is it visible, ma'am? The scans?
Yeah.
Yeah, I cannot appreciate osteophytes right now.
Yes, ma'am. Sorry, ma'am.
No, it's okay.
There are some.
So, what are you expecting from when you are doing imaging in a patient with neck pain with decreased movement? One is osteophyte. Second, in your case, second.
Second, degenerative changes.
Okay, good.
Yes, ma'am. And loss of cervical lordosis as patient is chronic RA. If we are looking for cervical involvement.
Not convinced. Next.
In your case, what would be relevant in a long-standing RA patient? What would be the one thing that you would want to see and you are suspecting that you want to rule out after imaging?
After imaging, we will like to rule out is there C1, C2 instability. The atlantoaxial subluxation is present or not. Or is there any spinal cord stenosis, cord compression, or nerve root compression?
So what intervals do you see? What are the intervals that you know of on the cervical imaging that need to be looked at to look whether there is an atlantoaxial subluxation?
Sorry, ma'am. Actually, I don't know about that.
No issues.
No.
So whenever a patient with long-standing RA with neck pain will come, think about okay, osteophytes, correct, correct, degenerative spine disease, okay, pannus formation. Because
Pannus
of
for
pannus, there is some features you will get. Again, CPPD, RA and CPPD, they with long-standing, they will there is common
crystal
association
deposition. Yes,
there.
ma'am.
Okay, in CPPD, what you will get in imaging?
Crystal deposition.
Yeah, and
Oh.
Dear moderators, just to inform you that we have 5 minutes more.
okay. So again, then atlantoaxial dislocation, you have to for
Yes.
that we want one X-ray or multiple lines we have to see to know whether we are dealing with that or not.
Yes, ma'am.
Okay, you should know about at this line and from where to where we have to draw.
Okay. Yes,
Okay,
ma'am.
and one criteria is also there. Next slide.
Yes. We have X-rays of his bilateral elbows, ma'am, as there was explained.
Next.
And we don't have hand X-rays.
It's okay. Nilesh, you just say your final diagnosis so that we can at least touch upon the treatment part.
Yes, ma'am.
Because we don't have much time left. We just have
Yes.
5 minutes.
And according to calculation, CDI and SDI-28 score, patient has high
Okay, next.
disease activity and test time of functional class 3. In final assessment,
Next.
yes,
Yeah.
in final assessment, patient has long-standing severe deforming erosive rheumatoid arthritis with active disease complicated by advanced hand and foot deformities, bilateral elbow involvement, rheumatoid nodules, and according to the CT report, pulmonary nodules too.
No, you cannot comment on the CT
Okay, ma'am.
report on your final
Yes, ma'am.
assessment. This is purely history and examination.
Yes, ma'am. Cutaneous rheumatoid nodules, subcutaneous rheumatoid nodules, and probably cutaneous rheumatoid vasculitis with significant functional impairment
You cannot comment on rheumatoid vasculitis also here. Okay.
without biopsy. Yes, ma'am.
Without biopsy also, and we don't have any typical features here. So
Yes.
for rheumatoid vasculitis also, we are following one criteria, or if it's not typical of RA vasculitis, we are getting only one skin findings. And
Yes.
are you convinced with us that RA can have skin involvement also?
Yes, ma'am.
Yeah, so you cannot comment on that. Again, you have to change your final diagnosis and tell to Digvijay that. Okay?
Yes,
After
ma'am.
changing that.
Yes,
Okay?
yes.
Yeah. Next.
And
how you
significant functional impairment, it's Steinbroker class 3, and high disease activity.
Next slide.
Then final lesson.
Okay.
Yes, ma'am.
Meera?
Yeah. So now you tell me, how are you going to manage this patient?
So, as the patient has arrived for the first time at us, we will have to check for if it is a seropositive RA. We will have to do blood investigations like RA factor anti-CCP for inflammation, ESR, CRB, that is acute phase reactants.
Do you
Uh,
think doing an RF anti-CCP is justified in this? Does it make sense in this patient? Will it change anything?
no, ma'am, DC actually, ma'am, in treatment protocols, like TNF alpha inhibitors or rituximab, that is anti-CD20, has better results with seropositive RA, ma'am.
So, but if he's seronegative and he's not responding to your conventional treatment, are you going to deny him rituximab?
No, ma'am.
So, if it's a proper clinically, people might differ on this, but in my opinion, if it is clear-cut rheumatoid arthritis, there's no need to do an RF anti-CCP,
Yes,
especially when we live in a resource constrained setting where patients have to pay out of their pocket.
yes, ma'am.
I think that. What would you say, Dr. Abhilasha?
Now, again, with your answer, like excellent answer, but with answer RF, we can do RF. RF is like you can tell with RF, it's we can give this treatment. But anti-CCP, again, why anti-CCP?
Yeah.
Yes, ma'am.
Tell me
Okay.
again why anti-CCP. There is one tricky answer is there behind this also. Why not why we should do RF anti-CCP? You can
Ma'am,
explain that RF
patient
is
with
like
RF, patient with RF or anti-CCP positive have high risk of developing
No. Your
RA.
patient is already is high risk. Male chronic
Yes,
disease,
ma'am.
informing RA nodule already has all the features except smoking. Okay.
Yes, ma'am.
So see, you just now told me that this patient can develop cryogenic vasculitis. Okay.
Yes,
In
ma'am.
cryogenic vasculitis, there is some other indirect investigations are there where RF can be positive. In that condition, anti-CCP can be negative. Okay.
Yes, ma'am.
So you can explain. You should know.
Yes. Yes.
2 minutes more, please.
Yes, ma'am.
What treatment you want to give this patient?
Ma'am, first of all, we will have to rule out if there is presence of ILD, presence of vasculitis by doing the skin biopsy, and look for fibrinoid necrosis. And according to that, we have to plan the treatment. If there is active vasculitis, we will have to plan for biologics, such as rituximab. And there is as patient has chronic use of Ayurvedic homeopathic medicine, we will also have to look for renal parameters and liver parameters, which will affect our treatment protocols. And the cervical X-ray, cervical MRI will be important to rule out instability and if there is need of surgical correction, emergency.
Can
And
we treat only with methotrexate?
yes, ma'am. Methotrexate. If RFTs and LFTs are normal, there is no renal or hepatic dysfunction, we can start patient on methotrexate with folic acid supplementation.
Mira, are you okay with methotrexate only?
And with if it is seropositive state, we can also start with combination of hydroxychloroquine. And if there is present of vasculitis, or ILD, we should plan for biologics such as rituximab. As TNF inhibitors like adalimumab have no very less role in treatment of vasculitis or ILD.
Okay.
Yes.
Okay, Anilesh. It's like excellent discussion. Thank you for your presentation.
Thank you so much.
Division?
Any final comments from moderators to Nilesh for making a good presentation, or how should he go ahead?
We told throughout that.
Yeah.
Okay,
Okay.
Nilesh, or you
Yes,
want
ma'am.
more?
No, your presentation was good, Nilesh. Just one suggestion. You can cut down on a lot of unwanted negative history.
Yes.
And when it is just a case presentation, obviously here it's a different forum, but in general, when it's a case presentation, you leave out all the laboratory part. It has
Yes.
to be
Yes, ma'am.
purely on your clinical examination and the history of patient.
Yes, ma'am.
Yeah.
Okay. You can stop sharing, Nilesh. Thank you for your presentation. Thank you, moderators, Meera and Abhilasha.
Yes, thank you,
Now,
Thank
ma'am.
you,
Thank you, sir.
now
Digvijay.
we have a guest lecture from Dr. Himanshi. I'll just yes. So today we have a guest speaker, Dr. Himanshi, who is a pediatric rheumatologist. She has done her DM from PGI Chandigarh, and she has done a fellowship in immunology from Rotterdam, Netherlands. She worked extensively in Tata Memorial Center. Now she heads her clinic in Pune. She has many publications, 60 publications, which are in various peer-reviewed journal. So we have happy to have her today. And just over to you, Himanshi, for your talk. I'll just stop the share. Hello, Himanshi. Can you
Hi,
hear me?
Victor.
Yeah,
Yes, I can hear you. And let me just start. I mean, you can see my screen, right?
yeah.
Okay, so here's my presentation. And thank you, Digvijay, and thank you to Team MRA for having me to present something which is very close to my heart in a very challenging academic session. I saw Nilesh presenting. I mean, it was an excellent presentation. He was thoroughly grilled by uh, Abhilasha and Meera, who were amazing examiners, and Nilesh did a great job defending himself. So it
Thank
was
you.
really stimulating to listen to that kind of discussion happening on a Sunday morning. So great job, Nilesh. Great job, Abhilasha and Meera. Um, so here I am. I'm a pediatric rheumatologist. I like to call myself an immunologist because um, I've done a lot of training in basic clinical immunology, be it lab-based, be it clinical, and my field of interest is actually stem cell transplants and the advancing cellular therapies. But something which is very basic has remained a fond favorite, is basic core pediatric rheumatology. So when I was approached by MRA to deliver a lecture, so they were giving me an option that you can discuss immunology and things that you do. I said, but pediatric rheumatology is something that is as important, and a lot of the audience here would be getting pediatric patients in their clinical practice, and this kind of an exposure where I can actually show you live cases, real life cases, could actually help some of these patients who are seen by adult rheumatologists. So moving on, let me just minimize this. Yeah, so what I'll cover is I'll briefly discuss the spectrum of pediatric rheumatic diseases, and I'll discuss how. So I won't be telling you what arthritis is, what vasculitis is. I'll just try to quickly tell you how the pediatric version of arthritis or vasculitis is different from the adult counterpart. So that is what I'll be covering. Then I'll be touching upon some aspects, some very central pediatric aspects like growth and development. I'll just have a slide wherein I show you how pediatric rheumatology training has been over the last few years, and I mean how we can collaborate on pediatric patients, how it's not just pediatric rheumatology's purview. I mean, it's a far wider outreach for these patients. Okay, so the central principle for pediatrics is that children are not simply small adults. So they are just not adults who come in small pockets. So for all diseases, all pediatric diseases, they differ from their adult counterparts, be it genetics, be it immunopathology, be it how they present, be it how they evolve, their natural history, the complications, response to therapy. And what is very important to understand is that even if when you're treating these patients, the treatment is happening inside a body that is still growing. So a lot of growth and development comes at stake when when they're hit by a chronic disease, a chronic rheumatological disease. So that is very important for everyone to understand, that the body that we are treating is still growing, is still developing. So all those things are as important as just the medication that we are giving them. So there are 60 plus distinct pediatric rheumatic diagnoses, and some of these diseases, they don't have any adult equivalent. Then between 0 to 18 years, it's a very crucial age. There's a lot of growth. You have pubertal spurts. You have a lot of development, be it, social, be it gross motor, fine motor, language that is happening along with, the growth of the child. And so there is one unique specialty that claims to bridge the sense of pediatrics and the complexity of rheumatology. So that is what pediatric rheumatology is. It kind of creates a bridge between two very difficult specializations. So the origin, the birth of pediatric rheumatology happened in 1976. It is a very, very famous picture. So there was a meeting that happened by ACR, and some of these people who specialized, who interested in pediatric rheumatology, they met at a place and they wrote first of the few guidelines and the chapters on pediatric rheumatology. So these are some of the disease. So I'll just tell you, these are some of the disease that, some of the variants of rheumatological conditions that are very, very different from the adults. So when we talk about our inflammatory arthritis, JIA, that is what we call it. And again, there are 7 subtypes. It's very distinct in its course and its complications. We have a separate subset of monogenic diseases, where we talk about autoinflammatory disorders, or we talk about immunodeficiencies, which can come as autoimmunity. Then there are some interesting autoinflammatory conditions like periodic fevers. Things like PFAPA is something that no adult rheumatologist would have any experience with. Again, a very, very unique disease like Kawasaki disease, which is overwhelming when it comes to children, but it's something which becomes very difficult for an adult rheumatologist to manage. And then, we have adult pattern disease like lupus, juvenile dermatomyositis, pediatric onset scleroderma, which tend to be a lot more severe, and they might have a lot more other complication than what we see in adult onset disease. So before I begin with the entire set of cases that I have to show you, things that we'll always remember is there are issues with linear growth when we are treating children with arthritis. So if you have a patient with active arthritis, chronic inflammation, it can cause local overgrowth or it can cause growth arrest. So limb length shortening, limb length discrepancies is quite common when you're treating patients with arthritis. Steroids, again, sometimes we are just way too liberal, sometimes we are very conservative when it comes to the use of steroids. And again, for us, monitoring the growth velocity. So I work with, I've been very fortunate that I have some really great adult rheumatology mentors where I work. And, so when they see me monitor the height and weight for every patient that I see, so I've started noticing that if they are seeing an adult patient, they have also somehow started, measuring the weight and height. So, I think now that I'm around, I would say that. So they have also realized that, these children, they need a lot more consciousness about their growth, their development. So that is very, very important for a child. Then some pediatric specific complications like uveitis. They're usually silent. They could be sight threatening. So again, screening intervals are stratified by what type of JIA you have, the ANA status, and the age of onset. And again, because this is not taught in standard trainings in adult rheumatology programs, so this is something, again, becomes difficult for an adult rheumatologist to see. Then discussions around puberty, just the entire pubertal hormones, the fusion of epiphysis, delayed puberty, menarche. So these are again very difficult questions. If an adult rheumatologist is handling these questions. Children, again, they are moving targets, so they keep growing, their weight keeps growing, drug clearance, volume of distribution, formulation. So it needs to shift continuously. There are many DMARDs wherein wherein the dose keeps changing as soon as children cross certain weight brackets. So again, it's a constant it's a constant change of medicine, constant change of the drug dosages that we are using, even if we are seeing children who are on stable doses for many years. So that keeps happening. So there are different rules, different criteria. So how pediatric framework works. So we don't follow the same guidelines. We have separate guidelines, be it for our JIA, be it for our lupus. So it's not the same clinical criteria that we use for classifications. For pediatric arthritis, diagnosis requires onset before age 16. So it kind of distinguishes it from adult RA by definition, not just by biology. ANA positivity in JIA predicts uveitis risk, not disease severity, which is usually seen with adult rheumatological conditions. And autoinflammatory diseases, they rely greatly on genetic and clinical pattern recognition. And again, that is rarely taught in adult training. So moving on, we've discussed how weight-based and body surface-based dosing is practiced in children. Formulations, again, there are a lot of problems. Children would not want to take tablets. Liquid formulations for all medicines are not available. Injectables become an issue. They just don't like injections. Problems with injections. So gastric intolerance is a lot more when it comes to children. There's side effects. So when you see hepatotoxicity and nephrotoxicity, children tend to tolerate all these medicines better than adults. But again, what dose, how much antiemetic to use, what can make them feel better? I can absolutely do a different session on the challenges that we face as pediatric rheumatologists. So it's not just rheumatology that we are doing. We're doing a lot more pediatrics than rheumatology. So I thank my pediatrics training for it. So yeah, so that happens when we are handling these patients. Steroids, how much of steroids you're using. You have to be very, very conscious with the doses. Optimization is a must. Sometimes we have to be a lot more aggressive with steroids as compared to our adult counterparts. Especially when the kids are admitted, they have, the severe manifestation. We are a lot more liberal, but again, holding it back, when to stop. So these are some of those decisions that are very, very different from what I've seen the adult patients, what they're being given. So our doses, the way it should be given, when should we withdraw it? So all those are very, very difficult. Then there are issues with vaccination. So, at what time, at what phase of the medication, the vaccines are again very, very important. And over the years, there have been, a humongous increase in the number of vaccines that we are giving children. So again, it becomes very, very important when you're treating chronic disease, when you're immunosuppressing them for a very long time. And then safety data. So when it comes to malignancy, when it comes to fertility, when it comes to cumulative exposure risk, it should be projected across 60 plus years of remaining life. You cannot just model it from adult onset cohorts. There are far lesser research, especially when it comes to safety profile. That's why for our patient, when we use biologics, and for that matter, any other DMARD, for us, we know that this patient has to live for another 60 to 80 years. So when it comes to, issues of fertility, when it comes to issues of malignancy, we are a lot more conscious. We tend to take 2 steps back and try to keep doses as less as possible for our patients. So arthritis. Okay, Nilesh, GALS. So this is what the the examiners were trying to tell you. So we have a pediatric version of GALS also, and it's called pediatric GALS. And whatever they told you was right, how, you start from one portion of the body, and then, systematically you move across the body so that you don't miss out on anything. So PGALS is again very, very pediatric based. We try to make it fun for the child so that, little kids, 1 year old, 3 years old, 4 year old, you need a lot of patience to make them get things done. So, when you see our clinics, we have toys, we have a lot of distractions around so that kids cooperate. So yeah, so we do have a pediatric version of GALS, and this is how it goes, and we do it in our practices. Again, this is how it's documented. So again, I'm not telling you about what arthritis is, how it's treated differently and all those things. They are more or less the same, but what I'm trying to tell you is the basics. So when you see a limping child who walks into your clinic, so it's not just arthritis that we're talking about. So if you see a hot swollen joint, a child who's irritable, a child who has fever, who doesn't just look too well, think about sepsis, think about septic arthritis or osteomyelitis. And again, it's pretty common in children, because especially in younger children, because of metaphysis being present in the joint capsule. So a lot more septic arthritis, osteomyelitis in children. And very small children, it becomes so difficult to actually know what it is. Sending them for MRIs also become difficult because of sedation and everything. So, very, 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 very challenging. Then if you see a child who has bruises, has pallor, who has night sweats, think of malignancy. Again, we have seen a lot of musculoskeletal presentation of acute leukemia. So again, this is something, if you miss a child with a malignancy, it's a nightmare. You just cannot forgive yourself. Very, very important to understand that some of leukemias can present with musculoskeletal abnormalities. A child who's had preceding upper respiratory tract infection, gastroenteritis. Think of reactive arthritis, a stiffness which is worsened by immobility, early morning stiffness, gelling, pain, loss of function. This is like an inflammatory arthritis. If you see a child who's waking in the night, he just cannot sleep because the pain is so bad. So, one or the other odd times when we receive a call from a patient that, say it's a Sunday and you're not working, and you get a call on Saturday that, they want you to see the child urgently because he's just not moving his limb. He's just very irritable. So that is when, you should think about red flag signs. And time and again, we have diagnosed patients with such problems. We insist that you have to get admitted on Monday for a bone marrow. And, there have been many times that we've been able to make a diagnosis of a malignancy for these patients. So if a child who's limping and the pain is exacerbated by exertion but relieved by rest, think about mechanical causes, think about growing pains. And if you see a patient who's a bizarre pattern, just things don't seem to fit into any of those things, think about psychosocial stress, think about child abuse. So again, just see how much of, variability comes into differentials when you see a child, just a child who has a limp as compared to an adult counterpart. So a very, very classical case, a 10-year-old boy with prolonged fever. He has swelling of multiple joints, right ankle, fleeting joint pains, which responded promptly to NSAIDs. And again, multiple joints were involved. So this was basically an acute rheumatic fever. Again, next patient is a 3-year-old, a young child with high-grade fever, refuses to walk for a day, has significant pain with external rotation of the right leg. Think about it, it's a 3-year-old. How much would he cooperate when it comes to examination, when it comes to PGALs? So nothing happens. You take a look at his CBC is an elevated WBC count, his sick looking. This has to be septic arthritis, and again, an emergency for us, has to be admitted and started on antibiotics. Debridement has to be done, especially if it's deep organs. This is a 4-year-old boy who refused to walk but was afebrile. He had an upper respiratory tract infection a week back, had left hip pain, again, not moving. 4-year-olds, yeah, not moving their limbs, but everything else was fine. Hip is held in flexed abducted position, and you're sure this is something wrong with his hip. So this is transient synovitis of hip, and again, can become really troublesome, can become a real problem with very young kids. It becomes very difficult to counsel them that, you don't need anything else. You just put them on naproxen, give them some rest. Becomes very, very difficult for you to counsel these parents. Then a 7-year-old who's had right knee swelling for 15 days, high grade fever. This child would wake up at night due to pains. We saw TLC and we saw that there was a lymphocytic predominance platelets. I mean, we expect inflammatory or septic arthritis to have, higher platelet counts and everything, but you see a platelets which are borderline. This is, you have to get bone marrows done for these patients. These patients are often acute leukemias and should not be missed. Then this is another kid, 8-year-old girl who has pain in the legs, mainly in the evenings, almost for a year. Pain is sometimes severe enough that, it makes her cry. She finds it difficult to fall asleep, gets, some relief by massaging, and she's otherwise active, normal, going to school. And no significant other histories parents have done. Parents are very worried because it's been happening for a year. I mean, parents might not be too much concerned if they have problems, but if they see their children having, even slightest of problems, it becomes a very, very big deal. But anyway, so this is a classical growing pains, and again, needs a thorough history, needs a thorough examination, because of course, before labeling something as benign and self-limiting, you have to have that much that much confidence that you've examined, you've seen the investigations, and then you can definitely reassure the parents that things will settle down. This another kid, 5-year-old boy, high spiking fever, has a very characteristic evanescent salmon pink macular rash, which is generalized for almost 15 days. Swelling. So he has arthritis of bilateral knees and ankle. So when you examine him, you see pallor, you see lymphadenopathy, you see hepatosplenomegaly. Chest X-ray also shows mild pericardial effusion. So, this is systemic JIA. So, the adult counterpart is, Still's disease. But systemic JIA, if you're seeing patients with systemic JIA, they have to be very aggressively managed. A lot of them end up having macrophage activation. A lot of them are delayed when it comes to a diagnosis, because they'll be getting evaluated by multiple doctors for a PUO. And you would have wasted a certain amount of time before they're actually admitted. And they have a very high threshold of getting into macrophage activation. So again, very active pursual of these cases is what is needed. And they do well if you start them early, but if they get into macrophage activation, it becomes really messy. So again, very, very important. And for systemic JIA, because it is such a bad disease to happen, for the other JIA, we take 6 weeks. I mean, everything should be happening for 6 weeks, but for systemic JIA, we have restricted it to 2 weeks so that we don't miss out on these things. So it's very, very important that a patient who's arthritis and a patient who's running fever has to be handled very, very aggressively. Okay, so fatafat, I'll just do this. Like if you see for JIA, it's just rapid fire. A young girl, a lower limb arthritis, fewer joints, it's oligoarticular JIA. And ANA is very important here, because the ones who have ANA positivity have very high risk of asymptomatic uveitis. So we keep screening for uveitis every 3 months. Older boy, lower limbs, fewer joints, think of HLA-B27 related arthritis, and they present with symptomatic uveitis. A young girl who has symmetric polyarthritis, his RF negative, label it as RF negative polyarthritis. They kind of do better than the RF positive one. An adolescent girl, multiple symmetric small and large joint involvement, deforming arthritis. This is more like traditional RA. We call it RF positive polyarthritis. And of course, they have chronic problems. Any age, high-grade fever, evanescent rash, think of systemic JIA, and it remains a diagnosis of exclusion, so actually needs a lot of investigations before you start steroids. So pattern of joint involvement is the most important clue for us for diagnosis rather than investigations. So, I mean, here there are 7 subtypes of JIA, and it roughly affects around 1 in 1,000 children. It is mostly idiopathic. So, it affects open growth plates. So there's a risk of limb length discrepancies or joint deformities happening later in life. Uveitis and asymptomatic uveitis needs routine screening. So a disease positive child, they're both still developing. The disease is still evolving. The child is still developing. So, you have to do plus and minus with medication based on that aspect. And you must weigh treatment based on growth, puberty, the vaccination schedules. So this is how it is. So you see, limb length discrepancies happening in children, joint contractures, because they sometimes. I mean, it's very difficult to keep a child still, right? I mean, even if a child say has transient synovitis or has an oligoarticular knee arthritis, who's say 2-year-old, 3-year-old. I mean, it's just very difficult to make them sit at a place. They'll have just some problems when they get up, but when they start walking, they'll just assume a posture wherein they can still walk around, they'll still keep playing around, they'll be limping and they'll be playing around. So there are higher chances of a joint damage happening. There's a higher chance of a specific subset of muscle to actually atrophy over time. So these are some of those issues which become very prominent with children. Again, so TM joint involvement. So some of these bad polygias that we see, they have TM joint involvement. So they have these small micronathias, which becomes very prominent. I mean, you can make them out in a crowd that your jaw just did not develop because you had arthritis. So they're very pediatric centered problems. And of course, steroid use, demineralization, it just becomes a very big problem during peak growth years. So again, diagnosis is harder in children. They would never let you do PGALs. If they're younger children, you would just not be able to, look around at joints the way you do it in adults. So you have to play around, you have to do jingles with them, and you have to make sure that you get a thing done. You have to examine. So especially when a patient comes to you for the first time. So I again have a very extensive pro forma that even beyond the complaints, you need to examine other joints. You need to see whether the child has a spleen or not. So these are the things that you cannot really miss. So it's very, very important. Children do not, it's a very limited self-reporting that happens. Whatever history you get it from the parents. And only when you examine, then they will say, oh yeah, dukh raha hai. But again, it's important that at least on the first admission, you have first time when you examine them before putting them onto steroids, you need to have like a full examination to know the extent of the illness. And then again, a lot of childhood illnesses like viral arthritis, osteomyelitis, or septic arthritis, growing pains, they may actually look very similar to just an inflammatory arthritis. So for you to pinpoint and say, this is the time for me to start medication. Okay, this no longer looks like a reactive arthritis. It becomes very difficult for someone who's just not used to seeing kids around. So that is when pediatric rheumatologists they become relevant. And again, lab patterns are different. We do not I mean, we hardly do CCPs. ANA is far more important to us, and then all these things are again very, very a lot more relevant in pediatric rheumatology, I would say. Okay, then, again, morning stiffness may show up as irritability or refusal to walk rather than, saying that it's a clear vein pain complaint. Again, visual analog scores, it becomes very difficult for you to assess how much improvement has it happened. And then, we tell them, kitne marks doge on 100. So, something like that, you have to play around with the child. I mean, I don't know how much of, I mean, we being pediatricians, we are kind of used to that much patience, that much, we can build that rapport with the kids. I mean, I don't know how challenging and how much difficult it can get for an adult rheumatologist, especially when you're seeing 100 patients in a day. So, I can understand. So then coming to pediatric connective tissue disorders, pediatric lupus, so around 5 to 10% cases of lupus can have onset during childhood. We see a lot more boys with lupus than what you guys see. And our lupus, a lot of times, I mean, I would say 60% of times our lupus would be picked up in the hospital. So our lupus are a lot more severe. They have a lot more acute presentation as compared to the adult counterpart. We see a lot of fever. We see a lot of constitutional symptoms. Rash is a lot more common. Arthritis is a lot more common in children. And all major organ involvements, be it renal, be it neuropsychiatric, it's a lot more common in juvenile lupus as compared to the adult lupus. And it goes without saying, we have higher anti-DS DNA titers, our complement levels are lower. So lupus nephritis is seen in up to 80% of juvenile lupus. So for us, that becomes very, very, for us, the renal, chasing the renal parameters becomes very, very paramount. We do a lot of 24-hour urine estimations. We do a lot more investigations for our lupuses as compared to what I see in the adults. So overall, children, they present with greater disease activity at diagnosis, and they tend to have a higher immunological activity. And it goes without saying that, there's higher morbidity, there's higher mortality when it comes to juvenile lupus as compared to adult lupus. So juvenile lupus has higher disease activity, more flares, they have greater cumulative organ damage, longer lifetime disease burden as compared to the adult counterpart. And what are the unique challenges in juvenile lupus? Growth retardation, delayed puberty, school absenteeism. Again, it's a very, very important thing to understand that if you're keeping a child at home for months altogether for health reasons, so you're actually fiddling with this mental health as well. So the moment the kid seems to be doing okay. For me, it's usually after 2 weeks of like a good dose of steroids. If they they seem like they're doing better, I always encourage that even if it's for 2 hours a day, even if it's like 3 days a week, just send him to school, because schooling is so much important. It's an entirely different field altogether, and the parents, they'll just keep bugging you. Infection हो गया तो diet का कौन देखेगा, उसका medication होता है उस time. You have to make them understand कि यार school जाना is so much important for a child's mental well-being, for a child's development, for the child to feel like himself. It's so important for him to go to school. So again, it becomes a very, very big issue. We have like multiple sessions of counseling that goes behind it. A lot of psychological stress, not just for the child, even for the parents. Medication adherence. Polypharmacy, so many medications they are taking, ma'am, especially when they are feeling better. So once they are in the acute phase, parents will be very conscious. The child would be taking medicines, but the moment they get into remission, the moment they get back into their 5 day or 6 day a week schooling, सुबह का वाइसलॉन लेना भूल जाता हूँ, शाम का एमएमएफ छूट जाता है. There are so many medicines that I'm taking, so it becomes so much difficult to kind of constantly checking it, and it just cannot happen by just saying कि तुम दवाई ले रहे हो. So we always tell them, bring your medicines, and we like literally do a test. बताओ कौन सी दवा कितने बजे लेते हो. So all these things, antihypertensive, especially the children with vasculitis, their antihypertensives become such a big issue, especially when they get back into their routine, it becomes very difficult. Then transitioning to adult care, again, very, very important. Fertility counseling is big issue when it comes to children, and long-term steroid toxicity is again something that we have to keep on discussing with the patients and their families over and over again. Neonatal lupus, we know about it, we've read it, but this is how it looks. So it just those transplacentally passed down autoantibodies can affect the newborn baby. So a rash, this is like a classical rash that happens. They can have hepatitis, they can have thrombocytopenia, they can have a heart block, and of course, again, a lot of halla that happens in the neonatal ICU, that like such and such a kid is born, and please come and have a look. He looks very sick. The rash is crazy, and you go and tell them, "Arey, theek ho jayega." And again, it becomes so difficult for you to counsel the parents. So till the time you're not confident, you've not seen it happening before, you just cannot reassure them. It's just so difficult. I'm sure the parents in the audience can understand how difficult it is. For a doctor to say ki theek ho jayega, don't do anything. It becomes very, very, very difficult. Okay, so moving on to the complexity of pediatric rheumatology. So there is something called as monogenic lupus. So this is one of those patients, a 6-year-old boy. This is from PGI. So this was a 6-year-old boy, fever, rash, oral ulcers, alopecia, very early onset, 2.5 years se onset hai, boy. Seizures, ANA immunofluorescence, 4+ speckled, anti-dsDNA negative. He was anti-SM, anti-SM, RNP positive, APLA positive. two siblings had lupus-like features and they came from a consanguineous family. So this was one child with C1q deficiency, so a complement deficiency lupus. And again, somehow because they have early onset, so a lot more of these patients are actually picked up by pediatric rheumatologists as compared to our adult counterparts. Moving on to myositis, inflammatory myositis. So our inflammatory myositis traditional is juvenile dermatomyositis, which comes with a lot more cutaneous features. We have a lot more, systemic features like fever. We have a lot more vasculitic skin ulcers. Calcinosis is a lot more common here. But our JDM, they have better survival. They have, lesser associations with malignancy, and we can actually counsel them theek ho jayega, as compared to the adult inflammatory myositis, wherein it's a lot more complicated, especially with the ILDs and association with malignancy. So our JDM, they tend to do a lot more better when it comes to mortality, but again, a lot of morbidity because of calcinosis, and some MDFIs have pulmonary issues. So that remains, and of course, growth issues. Um, so all those things, they skin hypertrophy, and all those things are very relevant when it comes to juvenile myositis, which is not that common in adult counterpart. For scleroderma, we see more of localized scleroderma or morphia as compared to systemic sclerosis. But other things like, it can come with limb deformities, growth abnormalities. Our internal organ involvement is a little less as compared to the adult systemic sclerosis. We see lesser renal crisis, we see lesser pulmonary hypertension, but like if you see a child with systemic sclerosis, you keep screening them, because you never know which one can develop what. But we see lesser systemic sclerosis in the juvenile cohorts as compared to the adult counterparts. Vasculitis. So again, vasculitis for us is not one disease across ages. We don't really follow the Chapel Hill consensus classification criteria. It's more of, we have our own Printo press criteria that we follow. And for us, ANCA vasculitis is not the commonest vasculitis. That is rather the rarest vasculitis that we see. We see a lot more IgA vasculitis and Kawasaki disease, as compared to other vasculitis. Other very important thing is our BP cutoffs. So for pediatrics, BP cutoffs are percentiles based on your weight, based on your height, based on your age. So a BP like 120 by 80 is very, very acceptable for an adult, but it would be, like really bad hypertension for a 5-year-old, for a 6-year-old. And again, you have to be comfortable with those criteria. You have to be comfortable with antihypertensive medication. You should know when to add, when to stop what. So again, it becomes very difficult for adult rheumatologists to be able to do it. And that is when, we can help. Then the newer monogenic vasculitis like DADA2, again, we think, every childhood pan that we see, we screen. We always screen for ADA2, and somehow, a lot of our pediatric patients, especially when I was at PGI. So once DADA2 came into picture in the late 2000s, rather beyond 2016. So, in PGI, we called up all our old PAN patients and we screened all of them. And 50% of those patients ended up having DADA2, and that's how we built our cohort. So DADA2 is a lot. It's something that you should not screen for when you see a childhood polyarthritis nodosa. And cutaneous pan is again a lot more common in pediatrics as compared to adults. So IgA vasculitis, HSP, I'm sure everyone has seen it, but it's primarily a childhood disease. It happens in children around 3 to 10 years of age. Frequently it follows an upper respiratory tract infection, and everything classic to non-classic we see in pediatric patients. We try to manage them as conservatively as possible. We kind of withhold steroids unless they have a gastric involvement or they have renal involvement. So a lot of our patients actually escape steroids. So as compared to what I see at other places, and again, it's a very, very scary looking disorder. The HSP rash is just scary, and the swelling that comes, the arthritis that comes. No patient, no parent would say ki, madam, I would just sit at home and relax if this rash is coming. I'm very scared. You do something about it. And it takes multiple sessions. Rather, sometimes I just shout at them, don't do anything. I'm telling you not to do anything, and you're constantly after my life. So that happens. So, you need to have that much patience. You need to have that much credibility to tell them, please don't add steroids, because, it's going to just mess things up. You can just catch an infection and it will become so difficult for me to manage further. So that kind of thing, to understand that, it is self-resolving, it will get better by itself. Again, it gets very difficult. So in most ages, in most cases, if it's less than 8-year-old, it is just self-limiting. Nothing has to be done. So only if it involves, any systemic involvement, like if renal involvement, and you have to be very, very periodically, you have to keep screening their urines just to pick up any renal abnormality at the earliest. And they can be as bad as lupus nephritis. So again, it's very, very important that the parents understand that you have to keep doing these urine routines. Even if it's twice a week, you have to do it. You have to send these reports on my number, and you have to make sure that I've read those reports. So this is this is how messy things can get. So this is how the palpable purpura in HSPs look like. Another very, very, very important disease is Kawasaki disease. Again, it's very, very unfortunate that a lot of pediatricians are not aware of Kawasaki disease. Some of these kids are actually infants. Like, we've seen Kawasaki disease happening in neonates. Most common, it's most commonly seen in children less than 5 years of age. Again, has no set diagnostic like test, no biomarkers that can tell you that this is KD. It's just a symptomatology which evolves over some time, that you have to be very, very conscious of, that you have to know. And you have to act really fast. Within the first 10 days, you have to pick up the disease. You have to start these patients on IVIG. Otherwise, 25% of these children can actually develop coronary abnormalities. Again, gets very, very difficult, especially when pediatricians keep saying, it's just some viral fever, it's just some dengue fever. So again, it's really impossible for an adult rheumatologist to be able to convince a pediatrician who's managing a small child. So just a brief overview of what Kawasaki disease actually is. So it's a vasculitis, it's a medium vessel vasculitis, wherein you see fever for at least 5 days, and then you see other things like a conjunctival injection, which is non-purulent. You see a rash, you see mucosal changes, you see cervical adenopathy, and then you can see things like edema over the feet. Children are irritable. And then you get periungual desquamation. I'm sure whatever you're reading here makes you uncomfortable. I'm sure. So this is, very, very small kids with fever. And again, if the pediatrician is just not convinced that, which happens again, and like there'll be hospitals where there's no pediatric rheumatologist, and the adult rheumatologist is called in to help consult on a patient, on a small child who has prolonged fever. Even if they're thinking about Kawasaki disease, somehow the pediatrician would be like, nahi, nahi, ye to dengue ho sakta hai, nahi, nahi, ye to adenoviral ho sakta hai. And, I know, because then they kind of ask me to come, and then I counsel and everything. So that has happened. And why it's difficult is because, it's a huge difference. If you can see, the list of differential is just so huge for Kawasaki disease that it can mimic practically any disorder. And I'm sure a pediatrician would be able to convince you, oh, ye to dengue hai, this is not Kawasaki disease. It happens. It has happened to us multiple times. And things become more tricky. Things become more difficult when you see an incomplete or atypical Kawasaki disease. And these are the patients who would eventually have higher percentage of coronary involvement. So, again, a totally messed up game. So just an overview. So this was like a classical KT that I saw. An 8-month-old girl had a very classical BCG site reactivation. Again, for us, BCG site reactivation in a small child with fever is KD. Fever, conjunctival congestion, rash, red lips, irritable, treated with antibiotics. They said, oh, okay, let's do an, if you're, this was a doctor's child. So the doctor said, could this be KD? My child is too small. They did an echo and they said, oh, this is normal coronaries. Please go away. You're all fine. So they were discharged, if you can see here, and CRPs are really bad here. So you'll see a CRP of 80, you'll see bad fevers, 103, 10, completely bad fevers, 102, 103. CRPs would be very high, as you can see here. So, just thoda sa CRP fall hua and they were discharged, and then there was recurrence of fever, and eventually, we kind of identified this and we gave IVIG aspirin, and now that child is fine. But so this is like something that tells us ki, chalo, we were right. So periungual desquamation that happens in defervescence of fever, and that was something that was there in this child. So this was an adult KD that we saw in Kawasaki in PGI Chandigarh, and they have also published this. So this was a 30-year-old girl, again a medical student, who had fever, red eyes, a characteristic dry erythematous mucosa. She had a generalized body rash. She also had an element type facial nerve palsy, and she had periungual and perineal peeling of skin. And because in PGI even the adult rheumatologists are very familiar with KD, so they could pick it up. So it was actually picked up in the adult rheumatology services, and she was treated with IVIG there. She required infliximab, and she did very well. She had no coronary involvement. So KD rarely can also happen in adults. So, I mean, I'm going to leave this because there's a lot more that I have. Just quickly rush through. Okay, the other vasculitis. So, ANCA-associated vasculitis is a lot less in kids as compared to adults, and GP is the predominant subtype that we see in pediatrics. There would be a lot more diffuse organ involvement, like subglottic stenosis, a lot of orbital disease, lung disease is something that we see in our ANCA vasculitis. And again, so all those weight-based dosings, and you have to see whether cyclophosphamide or rituximab can be used, and you have to wait against growth, fertility preservation, and infection risk, again, in a developing child. So all these, again, severe disease discussions, counselings are very, very, a lot more relevant in pediatric sitting. So polyarthritis nodosa, I've discussed that cutaneous pan and DADA2 are a lot more in consideration when you see a child with polyarthritis nodosa, and we tend to screen almost all our pans for DADA2. Takayasu arteritis, so when we see, I mean, both of us will be seeing Takayasu arteritis. It can be seen in adolescents. It's very much the same pattern, but we see a lot more systemic features. We see a lot more delayed diagnosis as compared to adult patients. Hypertension again becomes a problem, especially antihypertensives. Dosing becomes a problem in pediatrics. So pediatric vasculitis has a lot more IgA, has more Kawasaki. Adults have more ANCA vasculitis. Our classification criterias are different. BP criterias are different. For biopsy or for doing any MRI or CT angios, we also have to consider that you have to sedate the child. You have to take an anesthesia, a PAC clearance before you can do all these things. So, there are considerations for pediatrics separately there. So now this was the classic rheumatology that we like that we see. I'm moving beyond classical autoimmunity. Like what other challenging things do we see as pediatric rheumatologist? Okay, and even these, I'm talking about autoinflammatory disease, I'm talking about monogenic vasculitis, I'm talking about immune dysregulation, I'm talking about CRMO. So why should even an adult rheumatologist know these things? Why should he recognize? When do you phone a friend? When do you call a pediatric rheumatology colleague to ask, could this be that? So sometimes, some of these patients who've survived beyond childhood, you might actually see them in adulthood. So patients with autoinflammatory disease, monogenic vasculitis, CRMO, they may even, they grow up and they need care by adult rheumatologist. Some monogenic and autoinflammatory condition, they first present in adulthood, and they might just be masquerading as a refractory adult vasculitis, seronegative arthritis, or a PUO. And then sometimes when you make a diagnosis of a child, and there are adults in the family who could have a very similar phenotype, so they might need to be taken care of. They might be adults who might be mildly affected, or they might be just asymptomatic carriers who also need counseling about all of this. So how is autoinflammatory different from autoimmune? So autoinflammatory is driven by the innate immune system. I mean, autoimmune is more of adaptive immune system, T and B cell mediated. It's more of cytokines in autoinflammatory. It's more of cells and autoantibodies in autoimmune conditions. So what are the common periodic fever syndromes like FMF, TRAPS, Muckle Wells? So these are cryopyrin associated periodic fevers. Then there's something called as PFAPA, which I would like to touch upon. FMF. Again, I mean, if you're working abroad, if you've had some exposure of working abroad, so you would have seen patients with FMF who have like these periodic arthritis, peritonitis. They'll present with GI complaints. It would run in families. There would be multiple members in the families, and they do very well on colchicine. So again, FMF in certain belts remain one of the most common autoinflammatory disorder, and there are actual I mean, it's been reported in certain areas in India as well. CAPS, a lot of these patients are actually children who present with just periodic fever. Bukhar jo ja hi nahi raha, periodically aata hai, and will come with other signs of inflammation like say a rash, conjunctivitis. They might have some arthropathy. So a lot of these kids are actually picked up in childhood. And you need like, chronic IL-1 blockers for these patients, and many transition into adults. And that is when we need your help. So I mean, so you need to know how the phenotype is, when especially when we transition them to your care. Very important, PFAPA syndrome. So what is PFAPA? It's an acronym for periodic fever, aphthous stomatitis, pharyngitis, and cervical adenitis. It happens in young children. So it happens in children around, say, 5 to 7, 5 to 8 years, or even younger. And that is when they'll have these recurrent fevers. महीने की 10 तारीख को बुखार आता है for 3 days. And in between the episodes, kids are absolutely well, and the growth and development is happening fine. Again, remains a diagnosis of exclusion. They do very well on single dose of prednisolone, and they usually self-resolve. So again, a diagnosis of PFAPA is very challenging for us also. I mean, I can just imagine how difficult it will be for you, but it's pretty common. I mean, if you see such children, you would know that it's pretty common. We've discussed DADA2, the other, interferonopathies like SAVI, Ikadi Gutier. So this is something that, I mean, they can come in adult patients also. So an awareness, especially, I mean, the world is talking about uh, um, monogenic diseases, monogenic autoimmunity. So we are kind of getting there, especially the newer lot of rheumatologists. I mean, we should be aware of whatever is, happening new, whatever could be a likely possibility. Like patients with DADA, I mean, they have really bad diseases, and TNF inhibitors actually help them. The moment you put them on TNF inhibitors, they actually do well. So knowing about these disorders is actually very important, because, I mean, the science is progressing. You never know what small molecule or biologic will work for a certain disease group. So till the time we don't identify, we don't pick up these diseases, we will never know how to treat them. And then there's a huge subset of immunodeficiencies that can come, like autoimmunity. Things that you should think about, I mean, know about is ALPS, CTLA4. So they come with any autoimmunity, autoimmune hemolytic anemia, thrombocytopenias, big spleen. They can come like lupus. They can come like enteropathy. So so just a key, I mean, this is something that you should remember, that when do you think about a monogenic or, an immune abnormality, like a genetic immune abnormality in a patient, is when you see an autoimmune disease that presents in early childhood or unusually early onset in a young adult. Like for our case, if we see a very young lupus, if we see like a 2-year-old having features of lupus, we know this is not normal. So this has to be evaluated for an immune deficiency. If you see polyautoimmunity, if you see multiple autoimmune diagnoses in one patient, or a strong multi-generational family history, then there's some merit in working these patients up. If you see recurrent or unusual infections which are accompanying the autoimmune feature, say someone who's had recurrent staph, someone who's had aspergillosis despite being on very low dose steroid or off steroids, someone who's had Burkholderia or something. So these are the patients who actually need to be looked at from another angle. And we're like the younger us. The newer trainees. These are the ones who somehow should be a lot more comfortable treating these disorders as compared to people who've been practicing for many years. Then treatment refractory disease despite adequate appropriately dosed conventional immunosuppression. If you feel that there's just some like a pan which is just not getting controlled for years altogether, so those are the ones who actually need further evaluation for a genetic cause. If you see early onset strokes, liver-door vasculopathy, think of DADA2. If you see consanguinity or a known affected sibling, then again it raises possibility of a recessive monogenic cause. Then there's something called a CRMO. Again, it's a childhood a specific autoinflammatory condition wherein you see multifocal osteomyelitic type lesions, but they're usually sterile. Um, and again, we see a lot more in pediatrics as compared to adults. So not touching it. Okay. So why should a pediatric rheumatologist should lead these cases? So one is we are a lot more familiar with rare disorders because, I mean, early onset and monogenic is more of our expertise. Then genetics forward workflow, routine integration of genetic counseling, variant interpretation, and cascade family testing into clinical practice. We're a lot more comfortable reading the complex genetic reports that come. We're a lot more comfortable discussing them, with the genetic specialist. We're a lot more comfortable counseling the parents about antenatal diagnosis in the next pregnancy. So that's something that we are a lot more comfortable because we do it for so many disorders. Then growth and developmental issues are something that we are a lot more capable of in children to address. And because we keep seeing these patients, we have established partnership with immunology. We have genetics who's just on our call, and we keep sending our patients. We know the obs gynae, we know the orthopedics, pediatric orthopedics. So we are a lot more linked to other subspecialties when it comes to a holistic care of the patient. Family
Himanshi,
center,
sorry to interrupt you. You have 5 minutes more.
but I'm just almost on my last
Yeah,
slides.
yeah, yeah. Take
Yeah.
it.
Then family centered continuity. So it's just it's a family that has to be counseled as well. It's not just the patient that you're counseling, you're also counseling the parents. Sometimes they get their grandparents also. Everyone comes. And of course we have to there should be a structured relationship between us and the adult rheumatology that colleagues, because we have to eventually pass on these patients to our adult colleagues. So when should you refer? When should you co-manage? If you're suspecting something monogenic, if there's a refractory autoimmunity that you're considering, adult survivor of pediatric CRMO, CAPS, or DADA2. I mean, even the adult patients who have all of this, I think there's some merit in taking us in co-management of these patients. And if there's a family member of a genetically diagnosed pediatric patient, again, I mean, we'll be able to counsel them and help them. So patient is never just the patient. The caregivers also have to be counseled. There are issues with school, physical therapies, child life psychology. Needle phobia is a big thing. How they're looking, the fact that they cannot step out in the sun in school is a big issue. Alopecia becomes such a big issue for adolescent girls. बहुत bullying होती है यार, and psychological stress बहुत होता है, तो you have to support them throughout. Growth and endocrine issues, anesthesia and sedation. For every small intervention, you have to consider that इसको anesthesia देना पड़ेगा. So just a brief of how the training is. So we have a 3 years pediatric DM at PGI Chandigarh. We have some pediatric rheumatology training programs in Delhi, Mumbai, Kolkata, Bangalore, and then of course there's a pass out exams. But there's less than 100 pediatric rheumatologists who just do pediatric rheumatology in our country. Okay, so we have to transition and not just transfer when they are basically transition. So this is my last slide. So pediatric rheumatic disease is biologically and a clinically distinct entity. Treatment happens inside a growing, developing body. You have to change doses, you have to monitor, you have to do a risk assessment at every step. Diagnosis and surveillance relies on pediatric specific criteria. There are separate screening schedules. There's a different pattern recognition, and care is delivered through a multidisciplinary family-centered model, which is built around the child. Refer early and partner. Don't take over for pediatric onset disease, and engage as a collaborative transition partner as patients they approach adulthood. So thank you, and I'll be very, very happy to take questions. Thank you so much.
So are there any questions? Please put in the chat box. We have 5 minutes to discuss the answer. Any questions? Himanshi, I have one question. For suspected DADA, what do you do first? You send a rapid exam or you send for ADA2 levels, and where is it possible? Like for us in Pune, if we want to send a sample for ADA2, and rapid exam is available, I agree, but it will also take 12 to 14 days. But where to send this ADA2 levels? And how it is sent, what precautions to be taken while sending it.
Okay, so ADA2 enzyme testing can be done. I mean, it's done at Gangaram. It's also done at PGI, but वो बीच में होता है, बीच में नहीं होता है. But Gangaram is consistently, it's been doing it for quite some time. So they have a protocol, and the form has to be filled, and it's not very expensive. It's like around 1,500 rupees that have to be. You can do an RTGS or
Yeah.
just bank transfer. So around 1,500, you have to send, I think, an EDTA sample or a plain, maybe a serum sample has to be sent. It's all in the form that they circulate, and it
Okay.
can be sent via registered post to Gangaram. And I mean, within 2 to 3 days, they'll give you a report. And of course,
Okay.
when it comes to confirmation, you can do a rapid exome, which is again not expensive. It comes in 2 weeks.
Yeah.
Around 5,000 is what the cost is,
Okay.
and you can get a report in 2 weeks. So that is how you do it.
Thank you. It was excellent talk and great insight from you. Thank you for accepting this lecture. So thank you everyone. Thank you Nilesh. Thank you moderators Abhilasha,
Sir, one
Meera.
doubt.
Thank you Himanshi. Please ask.
Madam, as you excellent presentation, madam. Thank you. One, as you said, in IgA vasculitis, you should wait for 4 weeks. Don't give steroids unless it will interrupt the condition or if you're prone to infections. We accept that. If he is having severe rash, like both upper limb and lower limb, maybe something ulcerating, child, he want to go to school. In that case, what is your stand? Will you wait for 4 weeks to settle down, or you'll do something?
Okay, so HSP only if it has GI involvement or it has renal involvement or pulmonary involvement, या फिर orchitis. These are a few of those things. If that happens, that is when you bring steroids into action. Other than that, even if the rash is very bad, even if the arthritis is very bad, try to avoid steroids. Just put them on naproxen. And with experience, we have seen kitna bhi kharab rash hai, however bad the arthritis is, it will just go by itself. Then why, it's not like a steroid dalne ke baad, the moment you stop steroids, it will not come back. It is a very notorious disease that keeps coming and going back. So, I mean, just adding steroids puts them at higher risk of, say, gastritis happening. So you put them on steroids, they'll have one episode of gastritis, they'll get admitted in the hospital. Ki probably this is, GI vasculitis. And this small GI vasculitis is so difficult to diagnose also. I mean, you can't even pick it up on a CT angio. So you'll just, you'll be doing more harm than good. You'll be just putting other immunosuppression just for something which could be as simple as steroids. So avoid steroids as much as you can do. I mean, if the child has a lot of pain, he can't go to school, give him naproxen, put him on NSAIDs, like a good dose of NSAIDs for some time, ask him to rest for some time, but keep steroids away as much as possible. Steroids should not be given for a rash or for that matter, arthritis. So this is what it is.
Okay, thank you.
Thank you, Himanshi. Thank you everyone for attending this program. We'll meet again in the month of August.
Thank you so much. Thank
Yeah.
you. Bye.